Thyroid hyperthyroidism or thyrotoxicosis. Hyperthyroidism causes sustained high plasma level or concentration of both T3 and T4. It's often generalized increase in metabolic rate, evidenced clinically by, for example, heat intolerance, fine tremor, tachycardia, especially atrial fibrillation, weight loss, tiredness, anxiety, sweating, and hyperthyroidism when connect with biochemical feature may be associated with hypercalcemia, which is occasionally found in a patient with a severe thyrotoxicosis. There is an increase in turnover of bone cell, probably due to direct action of thyroid. Secondly, hypocholesterolemia, which is due to increase the clearance of low-density lipoprotein combined with cholesterol, and hypokalemia, which also occur associated with thyrotoxic periodic paralysis. In addition, the plasma creatine kinase may be increased, and so this will lead to thyrotoxic myopathy. Graves' disease. This is the most form of thyrotoxicosis and occur often in female rather than in males. It may be caused by a relatively autonomous secretion from a diffused goiter and characterized by exophthalmos due to lymphocytic infiltration and the swelling of retroorbital tissue of the eyes. Sometimes localized thickening, subcutaneous tissue of the chin, pretibial exodermal. Graves' disease, as it is autoimmune disease, thyroid disease characterized by a variety of circulating antibodies, including anti-thyroid peroxidase enzyme, anti-TPO, as well as being associated with other autoimmune disease such as type 1 diabetes, adrenal insufficiency, pernicious anemia. Thyroid antibodies are detectable in some cases, such as thyroid-stimulating immunoglobulin, TSI, which is directed towards epitopes of TSH receptor and thus act as TSH receptor agonist. Nuclear medicine tests may show a high radioactive uptake of iodine by the thyroid gland, which is iodine 131. Some causes of hyperthyroidism: first, or autonomous secretion such as Graves' disease, subacute thyroiditis, some metastatic thyroid carcinoma. Secondly, excessive ingestion of thyroid hormone or iodine such as amiodarone, thyrotoxicosis factitia, or maybe due to self-administration of thyroid hormone, administration of iodine to a subject with iodine deficiency goiter, Jude-Basedow syndrome. Rarely causes such as thyroid-stimulating hormone secretion by tumors, stroma ovary, thyroid tissue is an ovarian teratoma, excess human chorionic gonadotrophin, such as in molar pregnancy, pituitary resistant to thyroid. Subacute thyroiditis. This is destructive thyroiditis. From the name thyroiditis, the inflammation of thyroid gland, resulting in release of performed thyroid hormone. There are three subtypes of this disease: granulomatous or painful, lymphocystic or silent, and last one, painless postpartum. This condition is associated with extremely elevated thyroid hormone and no radioactive iodine uptake by thyroid gland or follicle. The clinical course progresses through 6 to 8 weeks of thyrotoxicosis, 2 to 4 months of hypothyroidism and return to euthyroidism in about 90% of toxic nodules, either single or multiple. In a nodular goiter may secrete thyroid hormones autonomously. The secretion of TSH is suppressed by negative feedback mechanism. As in Graves' disease, the nodules may be detected by their uptake of radioactive iodine or titanium, with suppression of uptake in the rest of the thyroid tissue, which called also hot nodules. Toxic nodules are found most commonly in older patients who may present with only one of the features of hyperactivity, usually cardiovascular system such as atrial fibrillation. Toxic multinodular goiter is also called Palmer disease. Rare hyperthyroid states. Judd-Basedow syndrome is hyperthyroidism in patient with excess iodide intake, for example from the diet or from iodine-containing contrast media. بياخذون الأيودين المشع. High iodine intake may be assisted by urinary iodide assay. بالإضافة إلى البلد يكون الأساي in urine. Metastatic thyroid carcinoma can produce thyroid. Patient with choriocarcinoma or molar hydatidform pregnancy have extremely high concentration of beta human chorionic gonadotrophin that can activate the TSH receptor. Rarely the pituitary tumor release TSH, resulting in thyroid treatment. Beta blocker drugs such as propranolol, which inhibit the peripheral conversion of T4 to T3, may be used initially. Additional treatment include use of such drugs such as carbimazole, propylthiouracil combined together, or maybe carbimazole inhibit the synthesis of T3 and T4. Propylthiouracil additionally inhibited T4 to T3 conversion. Some clinicians use block and replace regimen, such as carbimazole is used to block thyroid secretion and the stimulants exogenous T4 to maintain and replace the T4 concentration which is blocked previously. It is important to remember that carbimazole can have the potentially lethal side effect of bone marrow suppression, and the patient should be warned about infection such as sore throat and about the need to have their full blood count monitoring. Radioactive iodine can be used in resistance or relapsing cases. Surgery is rarely indicated but may have a place if there is a large toxic goiter that is exerting pressure, or if a drug therapy fails but radioactive iodine is contraindicated. كل الطرق كانت مسدودة، فالخيار الأخير هو هذا. Thyroid function must be checked regularly خاصة بحالة الوينتر بالسمر. مرات يقللها الطبيب يزيدها حسب الوذر أو الكلايمت أو seasonal, as some patient may become hypothyroid or maybe relapse after radioiodine or surgery. The progress of the patient being treated for hyperthyroidism is usually monitored by estimating plasma TSH, free T4 and free T3 concentration. We're trying to restore these to normal, although TSH concentration may be slow to normal levels. Overtreatment may induce hypothyroidism with a rise in plasma TSH and low plasma T4 totally and freely, also in addition to T3 and free total. And in some patients with a severe prolonged hyperthyroidism, such as in rising in plasma TSH, may be delayed because the effect prolonged or feedback suppression of T4 on the pituitary. Subclinical hyperthyroidism. Subclinical hyper may occur with a low or suppressed TSH concentration, but normal, usually high to normal, both free T3, T4 concentration in the blood. The condition may progress to full-blown hyperthyroidism with a suppressed plasma TSH and raised both free T3, T4. Subclinical hyperthyroidism may be associated with atrial fibrillation, decreased bone mineral density, and other features of hyperthyroidism. Laboratory investigation of suspected hyperthyroidism: the plasma free T3, T4 concentration are clearly high and TSH concentration is suppressed in a clinically thyrotoxic patient. In the face of suppressed plasma TSH clearly elevated, the plasma free T3 concentration confirms the diagnosis of hyperthyroidism. Remember that T3 or thyrotoxicosis, the plasma free T4 may be normal. If the plasma free T4 concentration is raised and TSH concentration is normal, suggestive of biochemical euthyroid hyperthyroxemia. Laboratory also, in difficult cases, determination of a plasma 6 hormone binding globulin concentration can help decide whether the patient is hyperthyroid, as it's lower in hypothyroidism and raised in hyperthyroidism. Euthyroid goiter: if plasma T4 concentration fall, enlargement of thyroid gland goiter may be caused by TSH stimulation resulting in cellular hyperplasia. Thyroxine synthesis may be impaired by iodide deficiency caused by drug such as para-aminosalicylic acid, or possibly by partial deficiency of enzyme involved in T4 synthesis. Under the influence of prolonged stimulation by TSH, the number of thyroid cells is increased and plasma thyroid hormone concentration are maintained at the expense of the development of goiter. Inflammation of thyroid gland, thyroiditis, whether acute or subacute, may produce marked but temporary aberration of thyroid function test. Ultrasound scanning can be useful in diagnosis of goiter and can be radiolabel uptake studies to see if there are hot T4 producing or cold non-producing nodules. CQ thyroid. Any source illness may be associated with low plasma total or free T4 concentration and may make the interpretation of thyroid function test extremely difficult. Plasma TSH concentration أما يكون ضمن الطبيعي أو أعلى بشوية أو أقل. TSH response to TRH may also be impaired. There may be impaired conversion of T4 to T3 with low plasma level of T3. Consequently, the assessment of thyroid function test is best deferred until the patient has recovered from the illness. يعني بمعنى أنا ما أودي المريض يسوي التحليل للثايرويد أو يسوي وظائف الثايرويد إذا ما يصير تتحسن حالته المرضية ويشفى من الداخل ويامن ويتست وينطيني القراءة false result. This is defined the euthyroid hyperthyroxemia condition in which either the plasma total or free thyroxine concentration is abnormally raised without the clinical evidence of thyroid disease. These changes may be transient or persistent with the high, normal or low total or free T3. Heterophilic antibodies to free T4 or free T3 should be excluded, sometimes removed. يخلون فد مادة polyethylene glycol حتى يخلصون ويطلع test free from this antibodies. بعدين اللي هي interfere with assay حتى exclude any causes physiological condition resulting in raised plasma thyroid binding globulin concentration. For example, حالة pregnancy concentration total T3 T4 are both elevated but usually normal free T3 T4 concentration. T binding globulin or thyroid binding globulin concentration is raised in newborn babies. Other causes in hereditary T binding globulin excess is X-linked, hereditary transthyretin excess, familial dysalbuminemic hyperthyroxemia FDH due to abnormal form of albumin. The drug also may cause hyperthyroxemia leading to euthyroid hyperthyroxemia such as estrogen, raised thyroid binding globulin, as do the 5-fluorouracil heroin methadone. Amiodarone blocks conversion of T4 to T3, resulting in elevation of T4 and reverse T3 concentration, which is inactive form of T3. Heparin, due to this type of drug, due to releasing of fatty acid, inhibit the free T4 binding to globulin. Propranolol inhibit extrathyroidal conversion of T4 to T3 in some patients with a certain illness. For example, hyperemesis gravidarum have low total and free T3 concentration due to reduced peripheral conversion of T4 to T3 in both in liver or in the kidney, because 5D iodinase enzyme is inhibited. This results in elevation of total and free concentration of the plasma T4. Some hepatic disorders, such as acute hepatitis, result in raised concentration of binding globulin and T4 and total T4. In up to 10% of cases of acute psychosis, total and free T4 concentration also raised. The exact mechanism is unknown, but this may be due to central activation of hypothalamic pituitary axis. Amiodarone and thyroid function is sometimes used to treat certain cardiac arrhythmias. This drug can be evoke hypothyroidism, partly because it interrupts conversion of T4 to T3. However, it contains iodine and can also evoke thyrotoxicosis by the Jude-Basedow or type 1 phenomenon. Conversely, it may elicit destructive thyroiditis and thyrotoxicosis with raised interleukin 6 concentration, which is called type 2 phenomenon. The drug has long half-life. الهاف لايف مادة تتراوح ما بين أكثر من شهر إلى 3 شهور، فتتراوح ما بين 40 إلى 100 يوم أو 100 days, and thus takes a long time to clear from the strategy for thyroid function, testing and interpretation. First line test of thyroid function as stated above. أقيس TSH، أقيس free T3 T4. T3 قليل استخدمه بس بحالات الثايروتوكسيكوسيس يكون له قيمة. فعندي TSH T4 اللي هو free زائدا free T3. كيف البلازما TSH؟ عندي 3 حالات راح تبين. الحالة الأولى لما البلازما TSH concentration يكون normal البيشنت و patient is clinically euthyroid. إذا أروح أبغى على free T4. If free T4 concentration is low, consider sick euthyroid or non-thyroidal illness. Certain drugs such as carbamazepine or phenytoin. If free T4 concentration is also normal with normal TSH, thyroid function is likely to be normal. If free T4 concentration is high, consider euthyroid hyperthyroxanemia interfering assay autoantibody. Second one, if TSH concentration is low, also I look at plasma free T4. If free thyroxine is low, consider sick euthyroid or non-thyroid illness, pituitary or hypothalamic disease, secondary hypothyroidism, or by certain drugs. If the free thyroxine is normal, consider sick euthyroid, non-thyroid illness, subclinical hyperthyroidism, particularly if clinically hyperthyroid, certain drugs such as glucocorticoid, dopamine that may affect TSH, free T3 or thyrotoxicosis, the free T3 is raised. Concentration or plasma level is increased. If free thyroxine is high with low TSH, consider hyperthyroidism. Drugs such as amiodarone or iodine excess, hyperemesis gravidarum, molar pregnancy, activating TSH receptor mutation. The last one, plasma TSH concentration is high. Also, I looked at free thyroxine. Free thyroxine low with the high TSH, consider primary hypothyroidism, while free thyroxine normal with the high TSH, consider compensated hypothyroidism, inadequate thyroid replacement for hypothyroidism, drug such as metoclopramide or domperidone or sick euthyroid. If both of them high, TSH high with the thyroxine free high, consider generalized thyroid hormone resistance or TSH secreting tumor or interfering assay or antibody.